We are absolutely delighted that Dr. Arnold is presenting the webinar today. He is Professor of Psychiatry and Medical Genetics at the University of Calgary and Academic Director of the Hotchkiss Brain Institute and Matheson Center for Mental Health Research and Education. And at that point, Dr. Arnold, I can ask you to begin.
Great, thanks very much. Pleasure to be here. I am going to start by sharing my screen. So just bear with me for a second here as I just find and share my presentation. Okay. Okay, can everybody see that? I'll put it in presenter view so that you can see the full slides as opposed to the side panel there. Okay. There we go. So yeah, please do let me know if there's any, Julian, just jump in, or others, please, in the chat, if there's any technical difficulties, any interruption in
Sure.
sound.
No, that's fine. It's absolutely
Or
fine.
video. Perfect. Okay, thanks very much. So yeah, I'll get started. So yeah, as Julian was mentioning, the topic of the day is diagnosing anxiety disorders in children. This is my understanding is it's part of a sort of two-part series, and that the subsequent seminar will be on more focused on treatment. So I'm really going to focus on diagnosis. I'll talk just to give a bit of general background around anxiety disorders in children, and just a little bit more about me. So Julian sort of introduced me in terms of my affiliations. So, but in terms of maybe my clinical experience, to some extent, my research experience has been in the area of anxiety disorders and OCD. I'm going to be kind of speaking to that kind of from the point of view of a clinician, maybe bring in a little bit of kind of what we know from the research, but mostly focus on a very practical overview of anxiety disorders in children and kind of on a how-to in terms of diagnosis. Just also, though, to begin, since as presenting from University of Calgary, would like to acknowledge the traditional territories of the people of the Treaty 7 region of Southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation, the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations, and also to note that the city of Calgary is home to Métis Nation of Alberta, Region 3. Here's my disclosures, and not really of relevance to this presentation, particularly as I'm not talking specifically around treatment. I do have funding for a pharmacological trial in OCD, but again, we'll be off topic for this presentation, and otherwise just receive support from granting agencies. What I hope to accomplish today is to describe the core diagnostic criteria of anxiety disorders in children and adolescents. And I'm hoping you're coming away with the capacity to differentiate anxiety disorders from one another and from other psychiatric disorders. And just a little bit about, I don't talk a lot about this, but I just thought I would add this, that maybe more broadly actually about the process of assessment, and in particular, the role that rating scales can serve in the assessment of pediatric anxiety disorders. I'll touch on that in this presentation as well. So I thought before beginning into the actual diagnoses, just to kind of highlight, why anxiety is so important. And I'm guessing I'm kind of speaking to the choir. Many of you are clinicians who would see this daily in your clinical practice, but maybe it's important to just kind of think about this, that, anxiety disorders are the most common pediatric mental health disorders as a group. They tend to overlap, as you'll hear a lot, but collectively, they're the most common pediatric mental health disorder. And interestingly, for a while, I think we debated whether there really was an increase in anxiety, whether there was increasing recognition of the disorder. But there's been this suggestion for a number of years now that anxiety disorders are on the increase, although I do think there is some contribution from the fact that, with decreased stigma and better mental health literacy, people are coming to attention. Kids with anxiety are actually being seen and assessed, which is a good thing, and that may contribute to the rise. I think there's actually evidence, particularly in the last few years, that there may genuinely be a rise in the incidence and prevalence of anxiety disorders. This slide on the right is a study that was done by a colleague at University of Calgary, meta-analysis of the global literature, and really highlighted that there has been an increase in, certainly if you measure clinically significant anxiety disorders based on rating scales, there's been an increase, and there's also there's evidence from other sources that clinically diagnosed anxiety disorders, so meeting full criteria, having seen a clinician, there has been an elevated risk, maybe particularly when we're talking about children and adolescents, a little bit in that older age group of adolescents in particular, but perhaps in younger kids as well. It's also important to recognize anxiety disorders because they can be sort of a first sign of mental health disorders that can develop later in life. So there's lots of evidence that having an anxiety disorder as a child or adolescent increases one's risk for developing both continuing anxiety, so this term of kind of homotypic continuity, the idea that you continue to have anxiety disorder, it may manifest itself differently as one gets older, but also increased risk for other disorders, depression, for example, later in life. I think another important concept is that really clinical anxiety disorder is sort of a tip of an iceberg. This really is a symptom. Many symptoms, mental health symptoms are like this, but I think anxiety disorders is maybe the prototypical symptom where some degree of anxiety, of course, is in fact probably a good thing. This really is a trait that's distributed in the population. And it's helpful, I think, in terms of also just in terms of explaining this to our patients and their families, that some degree of anxiety is adaptive and helpful. But clearly what we're talking about with anxiety disorders is the tip of the iceberg. So that there's this underlying level of anxiety that varies continuously in the population, but the ones who we see who come for clinical attention are that tip of the iceberg. But it's a pretty big tip, and it may be getting bigger. So that, again, just going, the slide I showed previously was about elevated symptoms based on self-report scales, which sometimes could give inflated estimates. But even if we just look at anxiety disorder, and these are pre-pandemic estimates, that already we were seeing a potential increase in diagnosed anxiety disorder of about 12.9% of the population. So it's a pretty big group of individuals. Of course, anxiety can change over time, and it's possible that our young people, especially if they do get intervention, may not meet criteria for a disorder later, but that's still quite a high prevalence. And just to quickly comment, go back to that slide, because I'm not going to go into in depth, but one of the things that I think is just helpful to think about is why this is. And again, I commented on, sort of language I find helpful when diagnosing anxiety disorders and communicating back to patients. Again, there's that sort of, message that there's a normal level of anxiety. This is an adaptive symptom. We're not aiming to get rid of any level of anxiety, but as you'll hear repeatedly throughout the criteria for the disorder, when we call it an anxiety disorder, it's because it's impairing, it's getting in the way, it's causing distress. So it's really kind of crossed that part of that tip of the iceberg is where it's actually causing problems for the individual, and it's no longer adaptive. And of course, there can be a variety of reasons for this. There certainly is, for example, there's a strong genetic component to anxiety. It tends to run in families, that tendency towards elevated anxiety. But of course, there can be a number of environmental risk factors that can elevate the risk for anxiety, early trauma being one, but certainly there are likely other environmental risk factors, both in terms of kind of longitudinal risk factors, like I mentioned, that early history of trauma, but also more proximal stressors. People can develop anxiety disorders in the context of a very stressful environment, and for a variety of reasons. Maybe I'll get kind of the meat of the presentation, which is just going through some of the diagnoses of anxiety disorders. I'm going to try and kind of highlight some of the areas. I may skip through some things a little more quickly than others. Because I don't want it to become tedious where I'm just entirely just focusing on listing criteria, but I did want to highlight, and maybe as I go along, highlight some differences, maybe give examples of symptoms as they present in the clinic, and then hopefully have time at the end for questions. I'm sure we will have time at the end for questions about maybe some of the finer distinctions between anxiety disorders and as I suggested in the objectives, kind of differentiation of anxiety disorders from other conditions. And just to anchor this, and that I'm basing the slides I'm about to show are adapted versions of the DSM-5 text revision. Technically, that's we talk about the DSM-5, but technically the most updated manual is the DSM-5 text revision, which is sort of the manual that we, as mental health professionals use for particularly in North America, use for diagnosing anxiety disorders, and is a useful standard. The As I say adapted because the criteria can get quite long. And so in some cases, I haven't listed every possible. Many of the criteria, for example, give multiple examples of symptoms. I haven't always listed those. So what you'll see will be will be a fateful rendering of the wording, but a little bit abbreviated from the diagnostic criteria. And here we are. These are the anxiety disorders. And I say pediatric anxiety disorders. These are actually the anxiety disorders in the DSM-5 because all of them can present in childhood, although there is a bit of a developmental continuum. So we have, and I'd have to go back and look as to whether this was partly by intent, but certainly the categorization of the DSM-5 does list them. They do list some of the diagnoses that tend to happen early in life first, interestingly. So, for example, separation anxiety disorder, selective mutism. We think of these largely as diagnoses of childhood. You can have technically either, but they're unusual, particularly presenting for the first time in adulthood. They're much more sort of childhood disorders, and there may be a developmental continuum to these. And again, part of the differential diagnosis that I'll mention later, of course, as we kind of look throughout this, is there's a developmental aspect to this. So some degree of separation anxiety, as we know, is normative at certain types of stages of development. So again, this is where it veers off what we expect in the usual developmental trajectory. But again, not surprising that maybe separation anxiety would be more common in children. And then going through the list, you see that we have selective mutism, specific phobia, social anxiety disorder, panic disorder. Here we're getting to a disorder that maybe is a little less common, but you can certainly see in adolescents, a little less common in our younger group. Agoraphobia, generalized anxiety disorder. And then we have the ones that are sort of secondary to other things and and I don't go into a lot of detail about the last category, the other specified anxiety disorder or unspecified anxiety disorder. I'm happy to talk about those if there are questions, but they're kind of, they are sort of categories that are there for people clearly have anxiety that's distressing or impairing, but they don't quite meet the criteria, basically. There's subtle differences between those two. So anyway, I'll start now with going into the specific criteria. So let's begin with separation anxiety disorder. And that is developmentally inappropriate and excessive fear or anxiety concerning separation for those to whom the individual is attached. Now, they have to have 3 of a possible 8 symptoms. And I'll just touch on these briefly. I'll maybe not read all of these word for word, but the kind of prototypical symptoms are, in the context of anticipating or experiencing separation from home or from major attachment figures, typically parents, there's a recurrent excessive distress. Similarly, there's worry about losing those same attachment figures. There's worry about experiencing an untoward event that will cause separation. Another symptom is just this refusal to go out, away from home. To school can be a big one. That kids with separation anxiety disorder, one of the major causes for school refusal, which is a sort of a broad-based category that may present to you, but one of the possible causes and a common one is about separation anxiety. The persistent excessive fear or reluctance about being alone and interesting it in home or other settings. So one classic way of asking this question is to get a sense of, like, can the child be in a part of the house? Like, can they be in the basement with other parents and when their parents are on the upper floor, things like that. And at a certain age, you would expect they can certainly do that. There's the refusal to sleep alone. That can be a big presenting symptom. Kids who go sleep, of course, there's lots of cultural and family norms around that. That can be a tricky one, but certainly that can be an aspect of separation anxiety disorder. And then finally, repeated nightmares, specifically about the theme of separation. Sometimes it can be basically they're experiencing in sleep some of their separation anxiety symptoms, that worry about something bad happening to an attachment figure, for example. And then finally, again, a common presenting symptom, common for anxiety disorders in general, this idea of somatic or physical symptoms, so headaches, stomach aches, et cetera. There's examples given the DSM-5. Those are the typical ones. When separation from major attachment figures occurs or is anticipated. Of course, these things can overlap. So, for example, the persistent refusal to go to school, symptom D, could be classified as symptom B, but it could be that the child part of the way that presents is the child says, I can't go to school today. I got a headache or a stomach ache, and it's really anxiety driven. So that can be a common presentation. Again, they don't have to have all of these. Important. This is true of many DSM-5 disorders, and including the anxiety disorders, and particularly separation anxiety disorder. They only have to have 3 of the 8. There's some kind of questions that I find useful, or just facts in some ways that about a child, like again, that are sort of specific examples of some of these that can be useful. So this worrying about being away from home. A specific example of that could be, and maybe particularly true as children get a little bit older, asking if can they be away from home, can they sleep overnight, even at a relative's house, or even more so when they get to the stage where kids are starting to have sleepovers or go to maybe an overnight camp. Can they do that? Were they able to tolerate that? If they had no problem at all with that, it tends to suggest maybe separation anxiety disorder isn't the issue. So there are kind of some specific examples that tend to show up again, and I'm sure you will be familiar with many of these or have seen these over and over again in kids who have separation anxiety disorder. And again, then here's just the kind of finishing this off, that duration criteria can be a little bit difficult to keep track, because the different anxiety disorders have they may be somewhat arbitrary. These are based on consensus amongst experts, but they just thought that it should be at least 4 weeks in children and adolescents to have that separation to meet the criteria and cause, again, this is just the criteria for most DSM-5, that clinically significant distress or impairment not better explained by another mental disorder. They give multiple examples of that in the DSM-5. Moving on to selective mutism. At one time years ago, this was sort of in a separate category, but I think it was written. I think since was a good decision was realized this was really very much in the area of anxiety. In fact, some people think of it as a variant of social anxiety disorder, which we'll talk about, that maybe occurs in younger children. So selective mutism is the consistent failure to speak in specific situations in which there's an expectation for speaking, despite speaking in other situations. So, for example, a child who says absolutely nothing at school, but maybe can talk with familiar adults like parents. The disturbance interferes with educational or occupational achievement, so it's getting in the way, or with social communication, has to be at least a month. And interestingly, I when I reviewed the criteria, I'd forgotten this one. That can't be limited to the first month of school, which is really interesting. So I guess it was felt that there's going to be a group of kids who have more difficulty adapting, but if after the first month of school they're speaking, you really shouldn't make this diagnosis. And very importantly, in a sort of diverse population, we have lots of kids who have English as a second language. You really have to rule out that it's not attributable to the fact. Again, if it's at school, maybe it's because they really don't. Their level of comfort with English as a spoken language is so low that they don't speak. But yeah, they speak at home and with other adults in their own language. And again, is not better explained by a communication disorder and doesn't occur exclusively during the course of ASD, schizophrenia, or another psychotic disorder. ASD realistically is the one that would be very much the biggest issue in terms of differential diagnosis in kids. So is there a lack of speaking, more just a lack of reciprocal social interaction more broadly? So next in the criteria is specific phobia. This is probably one that, and again, this might be my bias. I'd be curious for those of you who are psychologists or maybe work in sort of non-medical settings. I don't often see this as a presenting complaint in the settings I work, but mainly because I think I probably the kids I see would be biased towards kind of seeking, there are more medical interventions or more intensive interventions, whereas specific phobia may see more of these in private practice. But basically, specific phobia is a marked fear or anxiety about a specific object or situation. In children, the fear or anxiety may be expressed by, they may not say, I'm scared. They may be expressed by crying, tantrums, freezing, or clinging. The phobic object or situation almost always provokes immediate fear or anxiety. So it's sort of a stereotypic response. They see let's say they're afraid of spiders. Anytime a spider is seen, they get frightened or anxious. it's actively avoided, and that could be that could be one of the biggest presenting concerns. Kid who won't go outdoors because they're worried there'll be spiders, continuing with that example, or they endure it but with intense fear and anxiety, and it's out of proportion to the actual danger posed by the specific object or situation. Actually, the spider is again a good example because spiders are rarely dangerous, at least certainly not in Canada anyway. And that it lasts, it's quite persistent. Again, here's the duration criteria varying with the different disorders, but this one really has to be present for 6 months or more for it to be considered clinically significant. Again, significant distress, not better explained by another mental disorder. That's an important one because sometimes, like as an example, some types of specific phobias may actually be there may be a very specific fear, but it might be part of a broader picture. So a specific fear of something that's the example I gave of spiders or maybe insects. We do occasionally see that, for example, in OCD, where it's actually more of a contamination fear. They're worried of getting sick or that kind of thing. But if they have a broader array of symptoms that goes along with that, and they don't just have the specific fear, we may not make the additional diagnosis of a specific phobia. But again, I mentioned I don't often see this as a primary complaint, but it's a pretty common comorbid issue for sure. Lots of kids with anxiety have phobias of various types, and they can be specified in certain categories. And again, these are probably evolutionarily important fears. I mean, so there aren't too many people who are afraid of, and there's been studies that have talked about this. There aren't too many kids who are afraid of flowers. Kind of thing. It's kind of an unusual fear, but these ones are really common. Animals, particularly animals that we might kind of think of as being dangerous traditionally, like snakes or things like that, or I may give an example of spiders. The natural things in the natural environment, blood injection, injury, and again, these are all things that could potentially cause one harm. Actually, so there's sort of probably a reason why our brains are a little wired to be afraid of these things, but with a phobia, it's it's out of hand. It's like out of context and excessive. So moving on to social anxiety disorder. So social anxiety disorder is a marked fear of anxiety about one or more social situations in which the individual is exposed to possible scrutiny by others. I think this is important to distinguish from, and again, I think this is a continuum, so this can be tricky at times, but it's not just a child can be shy without having social anxiety disorder. There's certainly can be temperamentally a little bit slower to warm up in social situations. A child who maybe is a bit quieter but again, as we'll go through the criteria here, this is where there are some characteristic features that make this a disorder that's above and beyond kind of normal shyness. So because there's been some concern in the sort of literature and maybe in the media that maybe we overdiagnose this sometimes. We're a society that tends to perhaps favor extroverts, and a child who's a bit more on the shy side, maybe we have to be careful not to overly pathologize. But I think if we apply the diagnostic criteria properly, this is truly something that can cause impairment and distress and can be warrant treatment. So here's an interesting criteria. The anxiety must occur in peer settings, not just during interactions with adults. That's kind of a specifier for kids, which is an interesting one. So it has to be somewhat generalizable and include those peer settings. The individual fears that he or she will act in a way or show anxiety symptoms that will be negatively evaluated. Actually, that symptom is probably one of the most helpful in terms of it can be hard to get at with younger children, but with an older child or an adolescent, you can usually gather from what they're saying that some way they fear that they're going to be criticized and they're going to be viewed negatively in one way or another. You can usually get at that, and again, that's a helpful distinction from just having maybe temperamentally being a bit on the shy side. A shy child may not necessarily have that fear of negative evaluation. The social situations almost always provoke immediate fear or anxiety. And again, that similar to previous diagnoses, I think this was mentioned with separation anxiety, you get these behavioral responses that, again, if the child can't tell you, oh, I'm scared, especially a younger child, but if you see these responses, you can make the diagnosis and presume they have this symptom. They also talk about failing to speak in social situations, kind of an interesting one. Here's where an important distinction has to be made from selective mutism, where that is the focus, but that can certainly be a feature. Social situations are avoided or endured with intense fear or anxiety out of proportion to the actual threat. Again, these are things that are pretty typical of anxiety disorders, that out of proportion idea. lasts 6 months or more, and of course causes sorry for the typo in the last line, but it's basically clinically significant distress or impairment in social, occupational, or other important areas of functioning. Not due to substance or medical condition. Oh, and here's an important one, that there is a subset of kids where this is very focused. So there's social anxiety disorder, which is sometimes referred to as generalized anxiety, social anxiety disorder. But the key specifier in the DSM-5 is if this is specific, they meet all those criteria, but it's very specific to, let's say, having to give up a speech in front of their class or other situations in which, again, all the criteria met. Their fear is really about being negatively evaluated, but they're okay with, let's say, an interaction on the playground. But it's any performance situation, they freeze, they fear negative evaluation, they meet all the criteria, then that's performance anxiety. Panic disorder. So as I alluded to earlier, tend to see panic disorder in a little bit slightly older age group than some of these other disorders. The characteristic feature, the core feature of panic disorder is a recurrent unexpected panic attack. Now, pause here to just mention, and again, this is specified in the DSM-5, one can have a panic attack and not, one can have a panic attack and it's not always panic disorder. So for example, you can have a panic attack in the context of one of the other anxiety disorders. I just talked about social anxiety disorder. If your child's panic attack occurs exclusively when they're in a novel social situation, based on that alone, they wouldn't meet criteria for panic disorder. It's that unexpected. The classic question is do these symptoms just develop out of the blue? Again, sometimes there can be triggers, but at least they're somewhat uncued and spontaneous. They're not, again, better explained by another disorder like social anxiety disorder, as an example. And the characteristics of a panic attack, having said that, are unexpected surge of intense fear or intense discomfort that reaches typically the onset of this is super fast. I've fortunately, I don't think I've ever experienced a full-blown panic attack, but lots of people who, both patients and, friends, family members who have, kind of really describe this, as, again, overwhelming fear that occurs within minutes. This isn't in the criteria, but typically the offset is not, it doesn't last that long either, although the offset is a bit slower. But, if somebody says they have a panic attack and they said it lasts for several hours or a day, you start to think that's probably something more. It's not just a panic attack. Typically it is short-lived. And during which time, and I haven't listed them here just for the sake of brevity, there's a lot of them, but during which time 4 or more of, there's 13 symptoms listed occur. I'll give examples, say instead of like having them all listed here, they kind of fall in different categories. So there's the physical manifestations, which are, the heart pounding, short of breath. They tend to kind of reflect elevated, basically elevated sympathetic nervous activity, essentially like a fear, what you'd think of as a classic fear response. So they can be those kind of physical symptoms. There are the kind of more cognitive symptoms. They can be like, I'm going to go crazy, I am going to die. And then there's sort of the behavioral symptoms, although that sort of segues a little bit into the next part of the next criteria. So the behavioral manifestation of panic disorder, key one is that not only does one have panic attacks, but it starts to pervade other aspects of one's life. So it's not just when the panic attacks are occurring that one is impaired. In order to meet criteria for panic disorder, at least one of the attacks has been followed by 1 month of more, or sorry, the wording is a little awkward, but it's one of the attacks has been followed by 1 month or more, just too many ones, of one or both of the following. And those are, firstly, and it can be either or. You can have both, but it can be either or. Persistent concern or worry about additional panic attacks or their consequences, or a significant maladaptive change in behavior related to the attacks. That could be avoiding places in which you're worried a panic attack might occur, for example, or sometimes then it can be, a lot of avoidance and sort of limiting one's activities in general. And again, not due to substance, general medical condition. This is maybe particularly important for panic disorder, maybe even compared to some of the other disorders. I mean, although we have the criteria about substance or general medical condition, it tends to be not that hard a distinction to make. Panic disorder is a harder one. This is probably, of all the anxiety disorders, particularly in, again, older teens, or maybe going into young adults and older. Um, this is the one disorder that one may go to the emergency room because of the symptoms, assuming that they're physical in nature. Again, of course, you can go to the emergency room for maybe having excessive anxiety in other areas, maybe less commonly, but this is one where often they'll show up in the emergency room saying, I think I'm having a heart attack. And it turns out to be a panic attack and maybe due to panic disorder. So that's kind of a really important one there. Or another mental disorder. Again, that goes back to that issue of you can have that distinction. You can have panic attacks, but let's say have social anxiety disorder and not panic disorder. So if it's better explained within the umbrella of another disorder, it's not panic disorder. Agoraphobia is an interesting one. Agora is sort of the Latin marketplace. So that's sort of the genesis. Phobia is fear, of course, but comes into a lot of the other disorders. But agora is a specific one, and that is this marked fear or anxiety in one or more of the following 5 situations. They're somewhat different from one another, but they tend to be, these are the ones that occur. And one of them, and the reason I mentioned the fear of marketplace, it's this kind of being in this idea of being out and being either in a place that's really, being in, interestingly, could be in more open spaces or more enclosed spaces. But again, sort of stereotypical places where agoraphobia is experienced is using public transportation. That may just be a variation of the being in an enclosed space, feeling like you're trapped. But again, it can occur in just that feeling of being threatened, of being in open spaces. This is one that can be sort of modeled in animal experiments. One of the classic experiments for anxiety in mice is the open field, type of experiment in which, mice they tend to gravitate towards the sides of the cage because they don't like to be out in the open where they feel exposed. So again, these are a good example, again, among anxiety disorders, that to some degree, all of these situations may be ones that are, sort of driven. There's a good reason why our brain tends to maybe perceive threat in some of these situations, but with agoraphobia, it's clearly excessive. And and the other situations I haven't said out loud are the standing in line or being in a crowd or just generally being outside of the home alone. So kind of a range of experiences, but they're characterized by marked fear or anxiety. And a big part of this is avoidance. Avoidance, as you'll probably hear, is an undercurrent recurring theme throughout all the anxiety disorders, but it's very much the biggest problem typically for agoraphobia. It's this avoidance. And the avoidance is driven by the fact that perception that escape might be difficult or help might not be available in the event of developing panic-like symptoms. Agoraphobia used to kind of be lumped together to some degree with panic disorder. It's separated, but it still has that reference to part of the fear may be that they're going to develop panic symptoms or another incapacitating or embarrassing symptoms. The agoraphobic situation almost always provokes fear or anxiety. That's, again, kind of similar to phobias. It's this very stereotypical response, actively avoided, or interestingly, this is specific to agoraphobia. Sometimes they can be mitigated by the presence of a companion. But again, of course, let's say an older teen who should be able to go out on their own, if they always need somebody with them and it's driven by these fears, that could be agoraphobia. Or the situations are endured, but with intense fear or anxiety. Again, I'll just go through these quickly, but because some of these are just very typical of anxiety disorders, out of proportion to the actual threat, persistent, in this case, 6 months or longer, cause significant distress or impairment, and again, not due to a substance, general medical condition. Again, this would probably be a bit of a variant of what I said about panic disorder. The rule out could be that, well, if they develop these really intense anxiety symptoms, again, maybe they're worried there's something wrong with them. But if it's really clear, it only occurs, there aren't medical disorders, there are none that I can think of, that only occur when you're on a bus. So, that kind of thing, like that could be a way of distinguishing agoraphobia from a medical condition. Generalized anxiety disorder, one of the more common presentations. Generalized anxiety disorder is just more pervasive than some of the others. As you heard, agoraphobia is almost the opposite in a way, like a specific phobia. It's very, very focused fear. Whereas generalized anxiety disorder, as the name suggests, what's characteristic is just this generalized pattern of being anxious or worried about almost everything. But there can be characteristic things. I shouldn't say that. I mean, it doesn't have to be everything, but it would, to meet the criteria, it should be multiple things, multiple areas. Often they're kind of everyday things. So the child is always worried about school or worried about social situations, maybe not in the same way that kid with social phobia, but they're often ruminating about their social interactions. They're worried about school. They're worried about bad things happening to parents. They're worried about the weather. You get the picture, it's sort of everything. Sometimes you can ask questions that will tend to be, if a child has this, will tend to be positively endorsed. Like, so you'll ask parents or the child, are you a worrier, or have people said you're a worry wart, or you can use some kind of colloquial expressions for this, and typically they'll endorse that. Um, uh, it occurs more days than not for at least 6 months, about a number of events. Sorry for the typo there again, number of not evens, but number of events or activities. So that's the pervasive pattern. Key feature is the individual finds it difficult to control the worry. That's kind of helpful in children. You get lots of children who maybe a little bit they have a tendency towards this. Maybe they're sub-threshold, but if they're very easily reassured. I gave the example of being worried about school. Like, Mom, I'm worried. I've got like lots of tests this week. I'm really worried about it. And the parent says, don't worry about it. You'll get there, and the child says, okay, and moves on. They probably don't have generalized anxiety disorder. There has to be some degree of just really finding it hard to control the worry. As I alluded to early, often these kids are very reassurance seeking. That can happen in a lot of anxiety disorders, but it's very characteristic. Generalized anxiety disorder, they kind of drive everybody nuts by asking lots of questions and really needing lots of reassurance. And the anxiety and worry are associated with one of 6 symptoms. I didn't list them all, partly because they're, but I'll mention them again, give examples, and they're listed in full in the DSM-5. But the symptoms are things like, I'd probably end up getting at least half of them just off the top of my head, and give you some key examples. But initial insomnia, can't fall asleep, feeling restless or keyed up or on edge is one. Difficulty concentrating or mind going blank is another. Again, that last one wouldn't just be in the context of ADHD, but it really is when they're characteristically they're really anxious. Could be a test, or could be just that they're feeling overwhelmed and they say, yeah, my mind just goes blank. And again, of course, causes clinically significant distress or impairment. Again, this is a good one, because you do get kids, as I mentioned, there's a normative distribution of these kinds of normal distribution of these kinds of symptoms. Kids are anxious, but it's got to really get in the way of their lives, or cause a lot of distress for them to meet the criteria for generalized anxiety disorder. So getting towards the end of the diagnostic criteria, I did want to mention briefly the substance/medication-induced anxiety disorder category. May be important, particularly as you get into older adolescents who may be using substances. Many of them are using substances. And for these ones, I won't go into the detailed criteria. I mean, it's sort of common sense. It's like where that, but there is sort of, it's laid out in the DSM-5, but basically it's where, the anxiety is clearly triggered by a substance or medical condition. The ones that are listed in the DSM-5 TR are listed there. And again, these are kind of, I'm not sure if it may have been intentional. They're listed in sort of, an order of things are probably you're going to see more commonly. Of course, in terms of differentiation, you typically expect to see, either, they have a history of substance abuse and you're teasing it apart, or if they haven't acknowledged that, maybe there's other features that make you suspicious of substance abuse, maybe other physical features, for example. And they do specify that it can have onset during intoxication, withdrawal, or, and this is for medication use, after medication use. And anxiety disorder due to a general medical condition, and I'm not sure how many of you are physicians, but this is not the most common presentation. It's obviously, as you're hearing, it's far more common just to have anxiety disorders that are primary are way more common than any of these things that are listed, particularly in children. So your, index of suspicion doesn't always have to be that high, but just something to be aware of. And if they're also reporting maybe physical symptoms, being unwell generally, or just having specific physical symptoms, you may want to suggest if you are a physician, do a more thorough testing or physical evaluation, or if you're not, then maybe suggesting they see their family doctor. The kind of classic ones are, there's multiple examples in the DSM-5. The kind of more classic ones are listed there. These are varying degree of, all of them are listed because they can occur in children, although they're not, they're vary in terms of how common they are. The classic one is hyperthyroid, more endocrine ones like hyperthyroidism and hypoglycemia. Cardiovascular can occur. Congestive heart failure is certainly an example. Also, and maybe slightly more common in kids, not super common, but can occur as arrhythmias, heart arrhythmias. And then finally, respiratory illnesses, kids who get highly anxious in the context of asthma. Usually pretty easy to tease out. I mean, because of the shortness of breath, and most kids know when it's induced by their asthma, but something to keep in mind. Metabolic disturbance, and then things like epilepsy, neurologic concerns. Common comorbid conditions for anxiety. I haven't listed all the possible comorbidities. Suffice it to say that, like many psychiatric disorders, comorbidity is probably the rule rather than the exception, particularly internal comorbidity. I'm on a research study where we're focused on multimorbidity, like people having more than one thing. And there's this kind of discussion with the group, do you even call it multimorbidity when a person has multiple anxiety disorders? That's kind of the norm. So if you have, particularly for some of them, like if you, the probability if you already have social anxiety disorder of also meeting criteria for generalized anxiety is certainly greatly elevated compared to the general population. So there's high degree of internal comorbidity within this category. It's probably the most common, but other things to keep in mind and think about are depression, and ADHD, and OCD. Kind of, that's an area that I focus on in terms of my clinical work. And in fact, OCD used to be categorized under anxiety disorders. Anxiety is a common presenting complaint, but of course there's characteristic features that don't occur in anxiety, such as intrusive recurrent thoughts, and they tend to follow specific themes. Contamination, worrying about things being symmetrical or ordered in one's environment, for example, and characteristic behaviors that you don't see in the other anxiety disorders. Like classic one would be hand washing, but maybe checking, that kind of thing. So I'm segueing into the differential diagnosis a little bit. And the differential diagnosis includes, to some degree, the disorders I just listed, but it also includes other things that you should think about. Is this just a trait rather than a disorder? So lots of literature about the concept of, kids, and comes under various names, and there's various kind of very, very well-developed literature on studies of these traits, but just kids who are temperamentally anxious, they don't necessarily meet the criteria for anxiety disorder. Again, most easy way of distinguishing them is like, does it really get in the way of their life and cause significant impairment or distress? And if not, then they may just be temperamentally anxious, which, again, like I said earlier, we don't want to pathologize. It's sort of a variation of normal, but it can be subtle sometimes. When does one cross the line from anxious temperament to having a anxiety disorder? And again, I mentioned there's lots of constructs related to this concept, behavioral inhibition. Lots of work by classically Jerome Kagan, is our famous psychologist, researcher, who looked at kids who have this characteristic feature showing up in very early childhood, where they have difficulty like approaching things compared to other children. So they tend to be very cautious and so forth in their interactions, and then that goes on and develops. They tend to be at higher risk for having anxious behaviors, in some cases anxiety disorders later in life. I already mentioned OCD. ASD is an important one. So kids with ASD can both be anxious, just very specifically linked to their symptoms. So if they only experience anxiety, let's say when common symptom of autism spectrum disorder would be like, hyperacusis, like loud noises startle them, they get an anxious response. If that's the only time it occurs, we may not make the diagnosis of an anxiety disorder. But again, comorbidity is certainly quite high. So there are many kids with autism spectrum disorder who meet full criteria for other anxiety disorders. But just having anxiety as a symptom doesn't necessarily warrant that. So I did promise that I would mention anxiety rating scales. Maybe I'll just comment on assessment of anxiety in general, and perhaps I should have said this at the beginning, but some of this is probably obvious to many of you, but really anxiety is, I mean, the core aspect of diagnosing anxiety disorder is just doing a good clinical history, but using these criteria, and asking questions initially in an open-ended, but then in a, again, but then going into a relatively close-ended, like start off with, obviously what brings you here today, but then kind of ask questions that are just slightly more close. That if it's clear they have anxiety, good things to ask are like, what is it that makes you anxious, which can then maybe take you down the path of some of the different anxiety disorders, for example, um, uh, and uh, and so forth. But supplementing your clinical history, it can be very useful to use anxiety rating scales, and again, recommended. There are a range, and that's a little bit out of scope for this presentation to go into a deep dive on these, but I did put up a few that are commonly used, and I think I would say are well supported in the literature. So there's a scale called the SCARED, which has been used for many years. It's very useful in terms of kind of following response over time. It's specific to anxiety disorders. If you want to, actually, these are kind of going in order of kind of from more narrow to more general. So the SCARED is if you just want a rating scale for anxiety disorders, it's very good. One that's just slightly broader, but I would still recommend, and in fact is starting to be recommended by, for example, mental health research funders, is that should be kind of our core measure in child and adolescent mental health, kind of like any of you work with adults, it's a bit better established that, kind of the standard measures that are used in a lot of settings are like the GAD-7 for anxiety and the PHQ-9 for depression. RCADS is kind of the equivalent, is becoming the equivalent for children. And that's the revised child anxiety and depression scale. There's a slightly shorter version of it called the RCADS 25. I actually should have listed that there. That's probably the most practical, feasible one. This questionnaire is actually pretty straightforward. It really has symptoms from all of the major disorders kind of embedded in it. They're asked in a slightly different way but essentially you could screen for the diagnosis and see which criteria they're likely to meet based on the rating scale. But again, to emphasize, it doesn't substitute a clinical diagnosis, because we know that self-report and parent report measures, because that's another option, particularly for younger kids. And there are parent versions of both of these measures, have limitations. And again, speaking of parent version, if you want a very broad psychopathology screen, something like the Child Behavior Checklist, you have to purchase it, but it can be useful. And there is an anxiety subscale that's very well established. So I'm sort of winding down. I just put up some recommended resources, online resources. So there's both the international one, the ADAA website, Anxiety Canada. I know that bit of a plug for the Tourette OCD Alberta network. I know despite the name, there's lots of resources that are helpful, and I'm guessing many of the audience, part of your interest in this is that you see kids in that population. So definitely a general resource. I put up there one reference to the literature, which is other than specific ones I made on the slide. I did base some of the practical tips I gave, and including there's a link on this website to the rating scales that I mentioned, is from the Canadian Pediatric Society. They published a really useful position paper, and it's kind of nice because it's a good general, it's accurate but fairly general and useful for people seeing kids in community settings. And then just a little plug, we do have a research study related to anxiety, and if you have clients, patients who identify as being anxious, we define it very broadly. They don't have to have a history of being diagnosed with anxiety disorder, but basically kids who complain of anxiety. We have a study looking at the genetics of that, how genes can influence how anxious young people feel. So they participate in a survey, give a saliva sample, do some simple phone games to do cognitive tasks. And we very soon are going to have a online treatment as an option attached to this. So kids who need treatment, like they're not already in CBT, can, as a sort of a low intensity intervention, use this evidence-based treatment for anxiety that's self-guided and available on the internet, that was developed by colleagues in Halifax. So anyway, I'll end with my plug there for research, and pause and take any questions you may have. Maybe I'll stop sharing my screen so I can see all of you and you can see me as I'm answering. Julian, should I just look to the chat? And
yeah, thank you, Dr. Arnold. That was wonderful. Thank you. There are some questions there in the chat. First one is Lee Sherwood.
Great, thank you. So yeah, is it understood that these symptoms would be presenting in the absence of a precipitating triggering event? And it's possible, by the way, the question, Lee, was in the context of one of the disorders. Lee, were you thinking of one? Thanks for coming on screen because I can see.
It was the separation anxiety, because I know we've got young children where they've been exposed to a traumatic event. Obviously, then they tend to present with separation anxiety, but it's in context of that event.
Yes, great point. So I think the key response to that, actually, the role of trauma is an important one. I probably should have listed, I apologize, because I don't know if I listed, or if I did, I didn't say it out loud, was, again, the issue of trauma in general and PTSD should be on the differential diagnosis. So my answer to that would be, I think there's a little bit of clinical judgment there. Strictly speaking, one could meet the criteria for separation anxiety disorder, even if the initial context was a triggering event. I think the key characteristic would be that the persistence of this. So if they continue to meet all the criteria for, 6 months from the trigger event, I think it would be extremely important in the formulation and thinking about how to treat that child, that the importance of the trauma. Again, we should all be aware and have a kind of trauma focused lens. We're learning, we've learned a lot about this in recent years. And anyway, but in particular, in this case, I think it would be an important component of treatment. But I would say if they meet all the criteria 6 months down the road, and I actually can think of a patient I have who, a couple of examples, but one in particular where I would say this is the case. I would still say they warrant the diagnosis, but again, it's in the, you would see this as one of the underlying causal factors in their case.
I guess because I work in the area, I see so many kids impacted by high conflict parenting situations. So the separation anxiety is presenting itself, but it's understood in light of what this child is experiencing on an ongoing basis.
Yeah, absolutely. I think that's a great point to and maybe that'll, that will likely be touched on in the treatment seminar, that we need to factor all these things in, making the diagnosis as a starting point. But in some of the same approaches, but they would need to be adapted and sensitive to, especially the family context you mentioned, any treatment, particularly, cognitive behavioral treatment, which would be the typical for separation anxiety disorder, would need to kind of take those factors in mind. So thank you for that. Good question.
The second question there, do children present with irritability for generalized anxiety disorder as adults do?
That is a great question. And yes, I believe that is listed amongst the, I didn't go over them in detail, but there was the 6 symptoms of which they only have to have one. But yes, I think being irritable, sometimes you'll phrase it to a child and their parent as being more cranky. Absolutely. And in fact, they could warrant the diagnosis. They met all the other criteria for generalized anxiety disorder, and the only symptom in that category was just they're really irritable, then that would be enough actually to make the diagnosis. So that's a good point. That they certainly can present with irritability as a major feature. Irritability is an interesting symptom. I could go on about this because I think it's one that maybe we don't always think about enough. I think it just cuts across so many different psychiatric disorders. Sometimes traditionally we would just kind of lump kids with irritability maybe into oppositional defiant disorder or something like that, because we just look at the behavior. But realistically, I think irritability is a really important symptom to think about in multiple domains in mental health. And generalized, I'm glad this question was raised, because generalized anxiety disorder is definitely one of the contexts in which this can occur.
And next question, do you prescribe hydroxyzine for anxiety disorders in kids? Seems to be used more in USA.
I don't. And I don't think it certainly wouldn't be first line treatment here. So again, I'll just touch on it because I know there's a treatment seminar, but my go-to first of all, my go-to because is actually for anxiety disorders, and I think this is consistent with practice guidelines in the literature, is cognitive behavioral therapy. Anyway, cognitive behavioral therapy approaches. Medication isn't always necessary, depending on there's a number of diagnoses that I listed that I would almost never go to medication, like specific phobia or actually, I think separation anxiety disorder in isolation, if it's not comorbid with other anxiety disorders, it'd be kind of rare to use medication, to be honest, because there's such a behavioral component. It's something that can be worked with. And but if medication is warranted for moderate to severe anxiety disorders, then the typical first-line treatment would be the SSRIs, selective serotonin reuptake inhibitors. And so, yeah, hydroxyzine wouldn't sort of be in my list. But there are local variations, that sort of thing, but certainly in Canada.
Another question, can youth in provinces other than Alberta participate in the anxiety study in last slide?
I'm glad that was asked. Yes. Yes. In fact, although we have a site here in Calgary, and for Alberta broadly, so we've been focused on identifying and recruiting participants locally. It's actually a national study. So so youth can, and in fact, depending on where they're enrolling from, one of the things we already do, I mentioned this piece of adding the treatment, but we already do give them a list of local resources and that sort of thing. Thank you for participating in the study. If if you do need help for anxiety, here's some. We do tag that to link it to where they're coming from, where they're enrolling from. So yeah, so they absolutely could participate from other provinces. I know we're getting close to time, but I see another, and thank you for that.
Yeah.
And there's two questions, and one is I'm going to touch on the SSRIs in very young children because it's a follow-up from my last one. Yeah, so definitely children as young as, I'm sort of thinking of some of the prototypical studies that were done. Some of the trials for anxiety that people still refer to were done years ago. In terms of like prescribing for very young children, that's a great question. I'm cautious with younger children. I wouldn't say less cautious, still cautious, always cautious, but I would say I feel comfortable with children as young as 8, based on some of the trials. There have been trials and good ones done maybe as young as 6, but certainly 8 and up. There's good evidence that SSRIs are safe and effective. I would say with younger children, caution is warranted. I think if the symptoms are impairing enough, then I think there's a careful risk-benefit discussion because and with parents. And again, I'm going to sound like I'm giving plugs for lots of studies, but we do have the availability in the Western provinces of sometimes what I'll do, and it is in the context of a research study. That's why I'm saying this, because otherwise it can be expensive. Is we have the availability in Alberta of a research study where we can refer kids for pharmacogenetic testing, and so sometimes we'll do that, and particularly can be particularly helpful and sort of to think about with where those cases where you're not sure, kind of thing in the sort of younger age group, particularly the kind of the 6-year-olds. Anything younger than 6, though, I'm very cautious. Sorry, that was I meant to be a short response. It was a bit longer.
Just 2 minutes left, Dr. Arnold.
Okay, perfect. There is a good question about I apologize. I'm gonna go to the last one just because with 2 minutes, it may be just easier to answer. And if time permits, I'll look at the one that came up previously. Yes. Okay. Thank you. So illness, anxiety disorder. That's a great question. So that is on the, I gave examples on the differential, but on some lists, they will list the sort of those somatoform disorders. So prominent illness, anxiety, differentiating that from generalized anxiety, or on the one hand, and OCD on the other hand, can be tricky. If they're worrying about getting sick is really not that much more prominent, and it's sort of part of a general picture of being worried about many things. That might not warrant the additional diagnosis of illness, anxiety disorder. However, if OCD, one of the ways of differentiating it, typically with OCD, again, it would present in a particular way, like the particular concern about infectious disease, contracting an illness through germs, that sort of thing. And again, similar to what I said with the generalized anxiety disorder, if their only focus is on a particular illness and it's not really about contamination, but it's on like, oh, what if I get cancer and nothing else, then that would tend to maybe think about illness, anxiety disorder, as opposed to if they have other symptoms of OCD, whether it be contamination or other symptoms of OCD, and it just better explained by that picture. So yeah, as you can hear, there's some subtleties to this, but I think that phrase that's used a lot in the DSM as better explained by another disorder is really important. And very quickly, because I see there's a last question, I appreciate I'm time because it is a quick one. Is illness, anxiety disorder different than medical trauma? Medical trauma would typically be, at least the way I conceptualize it, would be if one has experienced medical procedure and they could meet actually criteria, full-blown criteria for PTSD, or maybe they're just experienced excessive anxiety as a response to the trauma. We talked about the importance of trauma later, but in response to a medical procedure or having had a medical illness. So I would see that as being somewhat different, where the illness anxiety tends to be a little bit more broader and divorced from the specific relationship to the trauma, just more, and they may never have experienced or had any personal experience with the illness, but they're just anxious about getting that illness. If that helps. Sorry, it's a quick answer, but to a good question.